Hey, what's up, everybody? John Millen here with MillenGroup Benefit Hackers. I'm going deep down the rabbit hole on this great book. If you're a CEO, CFO, a Chief Human Resource Officer, it's a great book. I've been giving this out for free. It's called The CEO's Guide to Restoring the American Dream, but it's really about controlling healthcare costs, which is killing people right now. So I've been giving this book away. I buy it myself on Amazon if you want a free copy. If you're an owner or CEO, I'll do that. I've had requests from people like employees and stuff, and I would love to just buy $20 books and ship them FedEx to every single person, but you can get your own book. But if you're a CEO, CFO, HR manager where you're really concerned about this and you want to have a serious conversation, I will send the book to you and then we can start discussing different things. But today, I'm going to talk about a piece in here. So I'm going to go deep down the rabbit hole. I heard this online. It's really funny. So it's kind of going a little deeper into a topic. This won't be super long, but it's really important. If you are an owner or a CEO, you have a healthcare plan. Now, I'm assuming you have more than 2 employees. So if you have 50, 100, 250, 300 employees, 1,000, whatever it is, then anything more than 50 employees, this is going to apply. Like if you got 10 employees, not quite so much. There's not much you can do if you're in that small group, but you're a middle group, large group, self-funded, level funded, partially self-funded, definitely. Healthcare is a pain in the butt because it's going up in price and going down in quality every single year, but we need it. And so on this, I want to go to something that talks about steering employees, incentivizing employees to do certain things. And on page 110, there's a little case study here. And I won't get into the case study, I'll let you read it, but it's fascinating how you can bend that curve down. This company, the trend was normally 8.5% increase every year, and they have a trend of 1.3%. That money, that difference goes to pay. They pay their people more. That extra money they're not sending to the insurance companies goes to hiring, marketing, all kinds of stuff. Why just send it? So there's a huge reason why you want to compress that. And there are things you can do regardless of what you've been told. If you're in that 50 plus market, there are things you can do. But here they talk about steering employees towards high value physicians and services and away from low value ones. Steering people to high value physicians and away from low value. Here's a context that I want you to understand. If you need a new car and you decide to buy a Lexus instead of a Kia, the Lexus will cost more, right? But the value, the quality is better. Sorry, Kia owners. I'm not saying it's a piece of crap. I'm just saying it's better. A Lexus is better than Kia. A Mercedes-Benz, for most cases, is better than a Ford. Now, it doesn't mean you need that. I'm just saying when you pay more for cars, most of the time the quality goes up, right? You follow me? If you need better shoes, like for me, when I buy good shoes, if I pay more, they last longer. They don't fall apart. Healthcare is the reverse. And this messes people up. They say, well, if I go to a physician that does a knee replacement and they're the most expensive physician and the cost is the most, then the quality is the highest. No, it's the reverse. The higher cost facilities, providers, organizations, vendors typically are the lowest quality. It's the inverse of everything else. And let me give you an example. And this example is going to play right into this whole section about how do you steer employees to do certain things? How do you incent them? Now, this applies to healthcare, but it probably applies to almost anything. You could have the carrot or the stick approach, right? You must do this. Or over here, if you come over here, right? Both of them can work. A lot of times employers don't want to have just one option and make people do things. So fine. Maybe that's later as you demonstrate the value. So maybe it's A or B. So you can go here or here. Either one is fine with us, the employer. You, the CEO, CFO, it's fine, A or B, but it's going to cost you different if you go to A versus B. And let me give you an example. And this is going to play into steerage. How do you steer employees towards higher, like they said, higher value and lower cost providers? And there's a couple analogies I use. If one of your employees came to you today and said, I need a new printer for my little desk, and I'm not going to use the Canon that you have. I'm going to use company money and buy an $85,000 saddle stitch, multi-press, digital printer, and I'm going to sit it right next to my desk. And you're going to pay for it because that's what I want. What would you say? You'd say, you out of your freaking mind? Are you smoking crack? Like, what is going on? That's exactly what we do when the employee comes to you and says, big Mr. Boss, Mr. Boss Man, Mr. Boss Man, whoever, I need to take a month off. I need to have my knee replaced. And you're like, oh my gosh, are you okay? Yeah, just need to go get my knee replaced. Okay, well, I hope it's fine. Let us know what we can do. You got book time, get better, blah, blah, blah. And they go get an $85,000 knee replacement. You didn't ask them where they were going. You didn't say how much it's going to cost. They didn't ask how much it's going to cost, but whose money are they spending? Are they spending $85,000 of their own money to get that knee replaced? No. Are they spending $85,000 of the insurance company's money? No. Are they spending the physician's money? No. Guess whose money they're spending? Yours. Your plan is paying for that. Somehow, whether you're fully insured, partially self, RBP, self-funded, level funded, that is company money. Money goes in and money gets paid out. That's the company's spend. So here's the thing. You don't want to tell the employee, sorry, you have to limp around for the rest of your career and I'm not going to pay for that. So you give them a choice. And that's where page 110, 111, and 112 talking about value-based care, getting better value at a lower cost. And here's the thing that people ask, and it's not that complicated. It's just really common sense, but the system will try to make it really complex, and the advisors you talk to might make it complex. There's only one reason why your healthcare costs go up, really. There's one. It's claims. You send money to somebody, either the insurance company or to your own trust fund if you're partially self-funded, and then you put money in and then you spend it. And the money you're spending is the claims that are coming in. So if you spend money on claims, your costs go down. So the way to control your costs over time is to control the frequency, severity, and magnitude of your claims. How often, the levels, and then the big ones that come in. That's really the game. Control the frequency, severity, magnitude of your claims. Now again, you get 12 people in your medical plan, you're small group funded, it's not going to work. So don't worry, but this is not, that strategy does not matter because you're community rated. You have over 50 enrolled employees or in the mid-market, large market, you know who you are. You're self-funded, level funded, partially self-funded, RBP. Those are all driven on claims. So $85,000 surgery. So here's the example. Once you get that in your head, this becomes once I tell people, once you connect the dots of what's driving it, you see things differently. Because you could have read page 110, 108, 109, 110, 11, and 12 about Langdale Industries here. Brian wrote this, Brian Klepper. And you're like, that's not possible for us. Yeah, that's just them because, they manufacture something, whatever they do. Wood products. Oh, we're not in wood products, we're nonprofit. Yep. See, I told you it wouldn't work. Until you see the problem in a different way, until you connect the dots for yourself, anything you're told, you're going to be like, I don't know, but you're okay. We should be okay with 5% renewal increase every year, or 7% or 8%. 8%'s trend, broker negotiated from 12 to 8, so that's pretty good. I have clients that are in 13, 14, 25%. You should feel really, really lucky, John, that it's only 8. In 9 years, your healthcare costs will double at 8%. The rule is 72, right? Brush off your old math skills. So, claims, the cost of claims and the quality of the service. And this is what's missing a lot in conversation is the quality. It's like, the cost is a $40 copay to go see the doctor. The cost is a $100 copay to get an MRI. The cost is an $85 copay for my Trulicity prescription. That's the copay. That's not the cost of claims hitting your plan. And it's very easy to control once you get that. So back to the example, primary care. How do you steer employees? You need a knee replacement. You go to you skip the primary care doctor because you can go directly to a specialist, and you get a referral to a knee surgeon or an orthopedic surgeon, and you walk in and you pay your copay of whatever it is, $100, and they proceed to tell you after they're there for a little bit, and maybe they run some tests, that, Bob, your knee needs to be replaced, and, it's up to you, but this pain has been how long? 3 years, and you're hobbling. We've reached a point now where that knee needs to be replaced. There's nothing left to do because you've told me you tried all these different things, and I concur. I'm going to schedule you for the surgery at the hospital right across the street here, and we're booking the OR, and we'll get it taken care of, and it should be pretty easy. And you're like, great, no problem, go back, and when it's all said and done, that cost is $85,000, but Bob doesn't care because, well, he does care because he's going to pay the fees and most likely outpatient surgery and maybe a day in the hospital, depending, maybe not, but you're going to max your plan out. Your out-of-pocket maximum will be reached, most likely. It's expensive surgery and testing and everything else, so $8,500 is your out-of-pocket max. But you needed to get it done, and you went on your way. I go to my doctor. I go to a value-based physician in my plan because my employer said you can go, when I designate that I need a knee replacement, then the system says, John, you can go over here to Dr. Smith, or you can go to where Bob went. If you go to where Dr. Smith is, there's no cost for the visit. There's no cost for the specialist when they refer you, if they refer you. There's no cost for imaging, MRIs, CAT scans, none of that. There's no cost. And in fact, if you actually need a knee replacement, you only have to pay $1,000 max. Your choice, $1,000, $8,500. You can go wherever you want. Where do you think most people would choose? Now, not 100% will choose Dr. Smith over here where I go, but a lot would. Now, the person that's going to choose over here where Bob goes, it's my brother-in-law. He's an orthopedic surgeon. He's the best in Richmond. Great. You should go there. That makes sense. Versus, I don't know, I Googled the best orthopedic surgeons in Richmond in 2020, and they showed up, and I called them. Fine. No problem. Probably good. But over here, it's going to cost me max $1,000. And the reason why, John, it's like that is because we've vetted the whole process that your doctor over here, over the Bob route, they do surgeries once a week. It takes them about 2 hours in the operating room. This track over here, they do surgeries 3 times a day. It takes them about 45 minutes. Why? The doctor over here that Bob went only does it once a week. It takes more time, needs more training. The team is not as adept, like a NASCAR team, right? Not practicing very often. It takes 2 hours of OR time that's built in 15-minute increments, plus all the other stuff. It's more expensive, $85,000. Over here where John goes, 3 times a day, the team works like clockwork. It's the same, assume it's the same outcome, the same quality. I would venture my route over here is going to be a better outcome, but just for the sake of argument, it's the same perfect outcome. Which is better for both me, the employee, and you, the CFO or CEO? Pretty easy. It's like, well, why would anyone go this other route? Exactly. Now you give them the choice. You steer employees towards high-value physicians and services and away from low-value ones. You're going to steer me to a system which starts where? A primary care physician. And that is on page 112. Insist on value-based primary care. Value-based, not copay-based. When I get steered to this primary care physician that is used to dealing with more complex issues for someone that's in their 50s, they then have an automatic referral tree to the specialist in that network that we work with that has been vetted to be high quality physician at the best price. We're not substituting quality. We're getting the best quality at the lowest price because we don't want readmissions. I don't want to get a sepsis infection because, oops, not quite used to working in this hospital. I do it once a week and I have a new nurse this time and This is a different ER that I'm used to, or an OR that I'm used to. And stuff happens that are bad outcomes. Most of the time not, but it does happen quite frequently. That is the point of this 15-minute and 3-second down the rabbit hole. That is possible when you get on a different track of your healthcare plan. When you look at your healthcare as a business unit, not just an expense line, it is a profit center of your company that continues to get more expensive, and it's draining profits out of your company. So you want that to be as low as possible with the best outcome, right? We're not putting everyone on a high deductible HSA plan. That is horrible for someone that needs a knee replacement, because guess what? They wait forever to get it. And boy, I wonder what their productivity is like at work. Wonder if they're driving a truck, how that's going. What about safety incidents? What about workers' comp claims? You know, all that stuff. How does it affect their home life? And then they fight with their spouse and their kids because they can't play ball, and they come home and they're thinking all morning long about stuff. That impacts your operation, whether it's a for-profit or non-profit. That issue impacts your organization in ways you don't even see. But you go this other route, like, man, what? I mean, I can go here? Yep, that's exactly how that works. So I hope this is helpful. One of many videos I'm going to put together about going a little bit deeper into this. And these are concepts, right? These are strategies that have been working for large employers. I was asked the other day, like, why haven't I heard of this before? It's because for years, Walmart's been doing it. Target's been doing it. Big companies have been doing it. You know, employers over 5,000 employees on their plan, they've been doing a lot of this stuff. Not always. You may be one of them, like, I've never heard of this. Doesn't mean it's always there. But that stuff has moved downstream to what I call the mid-market range, 50 and above. So 50 to 250, 50 to 500 employees in that range. It could certainly be more because each of these strategies address different things. So let me give you one final example. You have 1,000 employees in your medical plan, and I was on a call, I don't know, a couple weeks ago, and they didn't have 1,000. They had 600 self-funded. It's like, great. So of that spend, where is most of the money being spent? When you look at that budget, you have 2 primary buckets of expenses. And they paused. The CFO was like, yeah. And it said, what do you think those are? There's only 2 buckets in that entire annual cost. Claims and administration and insurance, right? There's like 2 major categories. You fund your claims into a separate one bucket, and that's what pays your claims. And most likely you have insurance, maybe stop-loss insurance, admin fees, pharmacy benefit managers, and you have your admin. And most likely your admin section of the bucket is only 20 to 30% of the total number. And so you can squeeze that down a little bit, but what about the 70%? Like, how are you managing the claims? What is your claims management process? How do you control the frequency, severity, and magnitude of your claims? It's 70% of your money spend. I don't know. And therein lies how these things work. So check us out, MillenGroup.com. Love to chat. Low key, low pressure. It's weird. I like this stuff, but I do. And it's helping people, right? The bottom line is, if we're overpaying and overspending, enough is enough. Like, how I'm a for-profit guy. Like, I like companies making a profit. I make a profit. I'm a for-profit company. I don't make a lot of profit, but I make enough to take care of our team and their families and have a little left over. So I like profit. But I see some of these profits being made, and they're so massive. And I'm like, that's coming out of us. That's coming out of the employers. Mostly, it's not coming out of Medicare. The government has caps on Medicare spending. It's a whole nother topic on a rabbit hole about reference-based pricing. That's a whole nother topic. It's coming out of corporate healthcare plans. That's where the majority of this profit is coming from. And so, you know what? It's time to grab some of that back and restore, use that money for something else. So let me know what you think. Hope this is helpful. We'll talk soon. Ciao.